Hello, everybody. We've got lots and lots of people joining us today. I'm Tessa Guttridge. I'm chair of the Young Dementia Network, and today's webinar on advanced care planning is a collaboration between the Young Dementia Network and the Dutch Young Onset Dementia Knowledge Centre. Very warm welcome to our presenters, Chris, Jayne, Orii and Romy, and all of you attending, of course, too. Before I hand over to our host, Professor Christian Bakker, who's the Young Onset Dementia Research Lead for the Netherlands, I want to remind attendees that you're not on camera and you're not on mic, but we really do encourage you to use the chat, and please do use the question and answer function, and we'll leave plenty of time, 15 minutes at least, for questions at the end. So I'm going to hand over to Christian now to take us away. Please, Christian.
Okay, thank you, Tessa. A warm welcome to you all, and I'm delighted that we have so many people attending. Today's webinar focuses on the importance and challenges in advanced care planning and shared decision-making in young onset dementia. And we know that from all diseases, dementia has the largest impact on people's capacity and functional ability to live their lives the way they want to. But how should we shape this process of thinking about the future and how to live well with dementia? What are prerequisites for the decision-making process regarding the initiation of care and support? And what can we as a healthcare professional do to support advanced care planning? To start the webinar today, we will have a conversation between Chris Roberts, Jayne Goodrick and Orii McDermott about the experiences of Chris and Jayne with planning ahead whilst living with young onset dementia. Chris and Jayne have both spent a lot of their time raising awareness and speaking to others about dementia in many countries. Orii is a senior research fellow at the Institute of Mental Health at the University of Nottingham. Don't forget to drop any questions you may have during the interview in the Q&A. And a very warm welcome to Chris, Jayne, and Orii.
Thank you, Christian.
Hi.
So I'm just in this privileged position to have a conversation and maybe just to start off with one or two questions to Chris and Jayne. So maybe just could you tell us a little bit how you started your conversation on advanced care planning as a family? How did it start?
I think it was just about having an honest conversation with each other. We've always been a very sharing family. We've always spoke about problems around the table, haven't we? And so I'd already learned that the advantage of being honest, of coming out, with my diagnosis, because people cannot see my diagnosis. So to be honest about it, people knew that I wanted some help or assistance. So I think it's having these honest conversations with the family that started it all off, wasn't it?
It was, but what we found out was that Chris actually told me he'd already written his advanced care plan. And I said, oh, great, can I see it? He said, yes, I've put it away somewhere. We still haven't found it now, 12 years later. But that did actually spark the conversation between us as to what do you want and what would I want? It actually allowed us to discuss what I would like, because anything can happen to anyone at any time.
And we didn't want anyone to have this guilt about not knowing what either one of us might want, in the case of advanced planning. We all make assumptions about each other's wishes without even knowing what they are sometimes. And we found that out by talking, didn't we?
Yeah, and some of the conversations, we're making very light of it now, but some of them were very deep and very difficult. One of Chris's choices is not to die at home. So that then eventually the question came around to, well, what is home? Home at the moment is this house, our family home. Home could be the care setting that he may end up living in at the point of passing over. And so we had this really difficult conversation as to what he meant by home and what he actually meant. What it boiled down to when we extrapolated the whole thing was he does not want to die in the family home. And that was very key for Chris. But it also was key for me to know that, because he doesn't want to die at home. So if Chris is in a care home at point of, at end of life, I'm not going to have him lifted up and whisked to hospital so that he doesn't die at what is that ultimately his home. Anywhere else doesn't matter, providing it's not in the family home. And we will do our best to enable that for Chris, but who knows what can happen in the future.
I just think that things are easier to deal with if someone dies away from the family home. And that's just myself, you know. I don't want to be if I live long enough and I'm in later stages, I don't want to be looked after by my family at home. They don't know what they're doing. So I have no problem going to a nursing home and being looked after by professionals. You know, I would rather that. So we've even chosen a home that I've picked. It wasn't necessarily the first one, which was absolutely beautiful, but you couldn't make a mess. You couldn't go outside. So I found one that I'm really, really comfortable with. And it also took away the stigma of me going to a home that Jayne was experiencing.
Or that I might experience in the future. We also made a point of never to make promises to each other that we may not be able to keep. It's very noble and very heartwarming to say, Chris, I'll look after you to the end. You will never have to go into a care home, because we don't know what will happen. And everybody's very afraid of care homes, but sometimes they're the best place for a person to be. They're the professionals. They're trained in how to care for somebody in late stages or whatever stage Chris may be at. That would then allow me to become his wife again, rather than his literal hands-on carer. And that, we hope, will work for us if it ever gets to that stage.
Can I ask, Jayne, was it because you said initially your views were different, and Chris, you had a very clear idea about going to care homes would be a best option for you, but Jayne, you said you just had to have a quite a difficult conversation, but how did you manage to negotiate? How did you do that?
It was very difficult, because Chris says at a certain point, I want to go to a care home. And I said, no, I'm perfectly capable of looking after you up to my ability. If I'm not able to cope, then we will see at the time. But by that stage, it may be too late. But with having these ongoing conversations and revisiting regularly, which we found out during the COVID lockdowns was very important, then we have been able to tease out what is best for us both. Because Chris does have to consider that whilst it, in theory, will be his end of life, you know, there's no guarantee that he will go before me, that he also needed to consider my emotions and my feelings on it. So having these conversations really allowed us to expand the topic into a wider thing, rather than just I'm going into a care home when I am at a certain stage. And Chris has decided that certain stage maybe when if he becomes doubly incontinent, or if he's no longer able to do personal care. And these will be the triggers that he may not be able to express to me at those times, but I will be aware of his.
Yeah, the earlier you can have these conversations, I think the easier it becomes. You get into a routine of talking, but it also, as Jayne just said, it's also easier earlier on, because you understand better. I understand better, which I probably won't be able to do so much. I'm not so good now.
He's able to articulate better the earlier stages, and we're very fortunate. Chris is more advanced than he may appear. I mean, those that have known us years can possibly see the advancement, but he's still able to articulate very well. However, some people don't have that luxury. They're not able to do that. So the sooner we can have these conversations, I think the easier it is, because it's something that's long away in the distance, hopefully. So we need to get those choices, both of our choices, down as early as possible. I did allude to COVID. During COVID, there was a lot of angst about oxygen, about life support machines. And Chris changed his choices at that point. He said, I do not want treatment. If I get COVID, leave me alone, you know, apart from pain-free care. Then as COVID progressed, oxygen became available. He said, okay, I'll have the oxygen, but I don't want a life support machine. And that life support machine choice never ever changed. I mean, I know we now know a lot more about those situations, but his choices changed as world circumstances change, or our local circumstances change. So that's another reason it's important to revisit. And if you had a terminal illness that means you're going to die in 6 or 12 months, what are your choices now? If you developed a cancer that said you're going to die in
no treatment. Is that
no
it?
treatment, yeah.
Yes. Yeah, I don't want treatment. I don't want to extend an already limited life I have. You know, it's better than dying, but my life is it's as good as we can make it, but it's nothing like my previous existence.
So that was one of the benefits for us that came out of the lockdowns and these additional revisiting, is that because we're talking 5 years ago, half a decade ago now, is that we were able to come to terms with the fact that if Chris does have a life, I think we call it limiting illness, whatever, if Chris gets a diagnosis of imminent death, no treatment, but that doesn't mean he doesn't want palliation. He does want to be pain-free and as comfortable as possible, but nothing to prolong life.
No, I want quality, not quantity.
Yeah, but just even your short conversation really shows the importance of the revisiting, and your views and experience and your values may change over time as well. I know we got a few minutes left, but do you have any advice for people? Because I had the privilege of working with you, so I kind of know you can have this open conversation as a family. But some people do struggle to start thinking about advanced care planning. Do you have any advice for other people who might find this kind of conversation quite challenging?
My best advice is to start this conversation before a diagnosis. You know, we're all going to die. So it's a fact of life. So we should all be having this conversation anyway, and then it doesn't become difficult if you're diagnosed with something life-changing.
I think in my case, where I am the person without the whichever diagnosis it is, you know, whether it's a dementia or anything other life limiting, I bring up the subject around me. It's okay, you have this terminal illness, so what will happen if something happens to me? You know, how will the family manage? What would you like? And then I can give my thoughts as to how I want or how I hope that the end of life or whatever may be. But that can then open up the conversation, because it's very hard to say, okay, you've got dementia. What do we do when you die? What do we do when you get to late stages?
But it's also about, it's not just about dying, it's about how you want to be cared for.
So by bringing the topic up around me, I'm fortunate because Chris brought the topic up. He's always been very pragmatic. But my mother developed dementia, and she also developed esophageal cancer. We were able to have some conversations with her. Unfortunately, we had left it too late. We never found out exactly what it was that she wanted. She was very much, oh, do what you like with me, do what you like with me, which made it very easy, no guilt or distress as to we did the wrong thing. But we do have friends where somebody has died within the past couple of months, and none of the family knew what that person wanted. And it really highlighted to us how fortunate we were to get a diagnosis that brought these topics to the forefront of our mind.
Okay, I think we got a few minutes. So my final question to you is that, how was it sharing your decisions with your children? Because obviously you've been having a conversation between you, but how did you find it?
We've got 5 children, and 3 of them have been really good about the conversations, and 2 of them not so good. You know, people are different, but it's just to give them a chance that if they do want to say anything, they can.
But it was also very good to stress the importance to them of the lasting power of attorney, of having a will. You know, they have their own children, but they also have joint properties. They may not be married, and actually having a will make things easier. I don't think they've actually done it. We really need to push that a little bit more. But we also know some professionals that give us all this advice who still haven't done it. So don't just think it's for us, it's for yourselves as well.
A good friend of mine used to say anything can happen to anyone at any time. And I think that's what you've got to have a conversation about. We actually found the children quite responsive to the chats, better than older people. And they're not children anymore.
No. But also you're highlighting the differences in them, your own children as well. So but maybe it's just, but your openness certainly will help for them to actually accept that as well, isn't it? So I think it's time to pass.
No, I'm saying it does help them because we can bring the topic up. You know, if there's something on the TV or something like that, it's like, by the way, have you done it yet? Have you done your will?
As casual as that. Okay. All right. Okay, I think it's time to pass over to Christian.
Thank you, Chris, and thank you, Jayne, for your openness and willingness to share your experiences with us. And thank you, Orii, for helping guide the conversation. Very much appreciated. I see some questions in the Q&A, so please don't be shy and drop any questions you might have in the Q&A, and we'll try and get back to these questions at the end of the webinar. For the second part of our webinar, I now want to introduce Romy Van Rickstal of the Vrije University Brussels, who will share with us some of her impressive work on advanced care planning in young onset dementia. So Romy, the floor is yours.
Thank you very much. I will start by sharing my slides. Does it work fine?
Works perfectly. Thank you.
Thank you so much. Thank you for the introduction, Christian. So my name is Romy Van Rickstal, and I currently work as a postdoctoral researcher at the End-of-Life Care Research Group at the Vrije University Brussels. First of all, thank you very much for having me here today. I was invited to give a presentation on advanced care planning in young onset dementia. So let's get started. Advanced care planning, or ACP, has been conceptualized as a process of communication between patients, family caregivers, and professionals in order to explore a patient's preferences for current and future care, including care at the end of life. ACP has conceptually evolved over time, and specifically in recent years, it has undergone a shift in focus from documentation to a process of ongoing support in communication and shared decision-making. The overall aim of advanced care planning is to increase the chance that the care received is in accordance to the care desired by the person, and this even at times when a person is no longer able to make or to express his or her own choice. Although advanced care planning is considered useful for anyone, regardless of health status, ACP is regarded as specifically relevant for those living with a condition that might jeopardize decisional capacity, such condition as dementia. Providing people with the opportunity to engage in advanced care planning if they want to is regarded as an essential element of high quality and of ethically justifiable long-term care after receiving a diagnosis of dementia. A few years ago, it was hypothesized by the Dutch Professor Koopmans and others that people living with young onset dementia and their family caregivers might have distinct needs and wishes in terms of palliative care, and specifically in terms of advanced care planning. So based on their active phase of life, it was presumed that these younger people would want more involvement in medical decision-making and would want higher autonomy in advanced care planning. However, unfortunately, young onset dementia is an under-researched group, and studies including people with young onset dementia themselves are actually nearly non-existent. So as an attempt to start bridging this gap in research, my promoters and I have decided to focus my PhD study exclusively towards young onset dementia. The overarching question of my PhD was, what are the experiences with, the preferences for, and the perspectives on advanced care planning of people with young onset dementia, their family caregivers, and physicians. In the search for answers, we conducted a series of qualitative studies. Qualitative simply means that these studies are based on words rather than on numbers. So on the one hand, we conducted 48 individual in-depth interviews with people with young onset dementia and their caregivers. And on the other hand, we conducted a focus group study with 21 physicians from various specialties that are considered essential in dementia care. So more precisely, it were GPs, neurologists, geriatricians, and psychiatrists. Today, there is one specific paper that will be my main focus. It's the one you can see on the left. That is an article that actually provides policy and practice recommendations for advanced care planning based on the insights of people with young onset dementia and their family caregivers themselves. However, here and there, I will also incorporate some results from our focus group study with physicians. That's the article you can see on the right side. Excuse me. The key message for today is that engagement in advanced care planning might be hindered if ACP is approached in an overly medicalized way, and if ACP is centered exclusively towards or around the patient. To accommodate advanced care planning to the needs of people with young onset dementia and their caregivers, it should be both presented and implemented as a holistic, a flexible, and as a relational communication process. It emerged that our respondents had a lacking awareness about advanced care planning and specifically about ACP as a communication process. So our responding people with young onset dementia and their caregivers initially equated the term advanced care planning to making medical decisions for the actual end of life. When they were then informed during interviews about the evolved, broader notion of advanced care planning, and when they started to discuss it as a communication process, we noticed that respondents paid ample attention to non-medical aspects of care, and that they also didn't make any division between medical, mental, and social health. A clear example of the importance of such a holistic view emerged, for instance, when the topic of residential care was discussed. The need to feel like one is treated with dignity, the need to have the opportunity to remain physically active as opposed to only having more sedentary services provided, the fear of being socially isolated. All of these aspects appeared intertwined in people's perspective on residential care. So broadening the conversation and using the question, what matters most to people now and in the future, as a starting point for ACP might create communicative space to explore patients' preferences and might make the process of advanced care planning more attuned to people's own ideas of it. In this regard, it is also important that awareness is raised among both professionals and among the general public about ACP as a communication process rather than as something only focused on its potential products, such as a living will. Advanced directives seem to be most useful in clinical practice if they are used as instruments for creating communicative space and when they are implemented as living documents to be rediscussed rather than when they are seen as the end goal of advanced care planning. So policymakers therefore hold a responsibility to provide a more consistent public discourse on the evolved view on ACP, and physicians hold the responsibility of informing patients and caregivers accordingly. We did find throughout our studies a clear need for information on advanced care planning and an explicit wish of caregivers for physicians to timely initiate the process. So we recommend physicians to fulfill an active role in explaining advanced care planning and initiating these discussions in case of young onset dementia. So adequate information provision really is a necessary first step in enabling people with young onset dementia and their caregivers to engage in advanced care planning. A flexible or a dynamic approach to advanced care planning would meet several of the challenges we currently face. So our studies highlighted that uncertainty is a very complicating factor for ACP in young onset dementia, and then more precisely uncertainty about what the future holds, at what pace, and which planning can be undertaken. However, simultaneously, we found a field of tension for patients and caregivers in the sense that at certain moments they needed to know more versus at certain moments they had no wish at all to know more. So sensitive and step-by-step information provision might incorporate thinking about the future into the attitude of living life day by day, as well researched and well known in dementia. If ACP, advanced care planning, were to be approached flexibly, it would also allow to synchronize the process of communication to the individuality of each dementia trajectory. So additionally, physicians also report to find advanced care planning in dementia difficult due to their own uncertainties. On the one hand, they experience a clinical uncertainty, for instance, uncertainty about the speed at which the condition will progress in a certain individual. But on the other hand, they also spoke about a moral uncertainty, in the sense that some decisions might be made prematurely, meaning that decisions are made for medical events that might happen years and years later. Throughout our focus groups, physicians also spoke of people with dementia who, as it goes, actually find their circumstances much more manageable than they had anticipated beforehand. According to them, this might make a person's current preferences insufficient to guide future care decisions. So a continuing, ongoing engagement in discussions might attune advanced care planning more to the principle of a person's evolving wishes and boundaries throughout a trajectory of dementia. Given that a level of uncertainty is almost an inevitable characteristic of dementia, it seems necessary to counter the potential prejudice that uncertainty is a ground for excluding advanced care planning from care. One of the aims of the ACP process is precisely to also prepare people for in-the-moment decision-making based on knowing the values, the preferences, the goals of care of a person with dementia. So the sum of all these findings actually underscore that advanced care planning as an ongoing dynamic dialogue about what constitutes adequate current and future care would be of benefit to all stakeholders involved. Also here, you might notice that we support the idea that the meaning of advanced care planning lies in its process rather than in its product. The third element we found is the added value of a relational as opposed to a purely individualized approach to advanced care planning. And this since familial relationships appear to be a cornerstone for ACP in young onset dementia. So only a person-centered approach might therefore actually not be sufficient in case of young onset dementia, although a person-centered approach is usually recommended for dementia care as well as for end-of-life care. Regardless of our respondents not having any or barely having any experience with advanced care planning, they did elaborate on the potential benefits of engaging in the process. And these benefits actually mostly related to the family caregivers. So concretely, both people with young onset dementia and their family caregivers thought that advanced care planning could lower emotional burden for caregivers. Despite a wish for dialogue by most of the caregivers in our sample, advanced care planning communication actually barely took place. In this regard, caregivers appeared confronted with conflicting demands. On the one hand, they wanted to discuss the future to meet their own emotional needs, but on the other hand, they refrained from bringing up the topic to their loved one with dementia in order to protect his or her emotions. To meet this complex dilemma of divergent needs, it has been suggested previously to frame advanced care planning as an act of care from the person with dementia towards his or her caregivers. Our studies indeed confirm that people with dementia regard advanced care planning as a potential mechanism to help safeguard their caregivers' emotional state. Additionally, our respondents with young onset dementia who had, for instance, made financial arrangements or who had discussed or even made funeral arrangements, for instance, they clearly showed to prioritize their caregivers' well-being. Moreover, our study participants highlighted how crucial it is for care to target an entire family as opposed to only target a person with a diagnosis. All of the former shows that people living with young onset dementia do not think or act in a void, which is centralized exclusively towards them as patients. We could therefore think of advanced care planning, but also of autonomy as being relational in nature. By doing so, we would acknowledge relationships as being an essential part of decision-making, and we would thereby also pay attention to how relationships might enhance the proper exercise of autonomy. In medical practice, professionals, for instance, could raise the topic of these mutually protective roles between the person with dementia and his or her caregivers to, again, create broader communicative space for advanced care planning. Lastly, our respondents also spoke quite elaborately about the stigma they experience from others in day-to-day life. They spoke about feeling discriminated against and about feeling underestimated. They said that people easily and wrongfully assume that a person with dementia is no longer able to do or to understand certain things. Family caregivers gave us the clear recommendation that advanced care planning in dementia should focus on a person with dementia's abilities rather than possible disabilities. And this recommendation could actually be considered a reply to the stereotype described by patients themselves, namely as people with dementia no longer being competent to do or understand certain things. So providing people with the opportunity to engage in advanced care planning if they wish to might in itself be a means to counter such stigmatic beliefs, since it would allow people with dementia to self-manage care and have their capabilities addressed and utilized. This brings me back to the key message of the day, namely that engagement in advanced care planning might be hindered in young onset dementia if advanced care planning is approached in an overly medicalized way and if ACP is focused solely around the patient, him or herself. To accommodate advanced care planning to the needs of people with young onset dementia and their family, it should be presented and implemented as a holistic, flexible, and relational communication process. So, as opposed to advanced care planning being focused on documenting decisions for the actual end of life and as seen as something that has to be done for the moments in close proximity to death, and as opposed to advanced care planning being focused on its products, such as advanced directives, rather than on its process, we recommend advanced care planning to be centered around the question, what matters most to people now and in the future? And we recommend doing so by having a holistic, a flexible, and a relational approach at the forefront when engaging in ACP with people with young onset dementia and their caregivers. Thank you very much for your attention. Please feel free to ask me any questions. I know we are on a tight schedule, so if some of the questions cannot be addressed today, you see my email address on the slides. Please do send me a message and I will reply.
Thank you so much, Romy, for your excellent presentation. I really enjoyed listening to you, and it was great to hear that you have a lot of research on this topic currently going on. There are many questions in the Q&A, and I think it will be good if Chris and Jayne, you maybe also switch on your camera again and your... Okay, welcome back. And maybe Ori, you as well. There are some questions we may want to discuss. We have a question from Kate Fellows, and I already discussed with Chris and Jayne if they're willing to answer this particular question. And it's a question if, Chris, you have an ADRT in place, and that's an advanced decision to refuse treatment. Could you say something about that?
Yeah. As you heard, paperwork doesn't do very well in our house. It gets lost. So I've got my tablet, which is my backup brain, and I put everything in notes. So yes, I have got one, but it's wrote and signed by myself in my notes, and Jayne knows where to go and look for all this. I have notes on my funeral. I have notes about the care home I want to go to. So everything's in my notes on my iPad.
We haven't actually have anything formally written down that we've given to the medics or the GP or whatever. But Chris's young onset CPN is well aware of his choices and the fact that he's got it all written down in the iPad. But I am fortunate in that I can advocate very well for Chris if he's no longer able to advocate for himself. As you can hear, he's still articulate enough to do that. But one has to know what Chris wants so that we can actually insist at the point of time that somebody may be overriding his decision, that this is what he wanted, this is what we have in place, and we have the young onset CPN to support that. Because Chris also has, there was something about hidden disabilities. Chris also has hidden disabilities that can't be seen, obviously, clues in the name. He has emphysema, COPD, which can cause him distress with breathing.
Okay.
He has bronchiectasis. He has rheumatoid arthritis, which gives him chronic debilitating pain. And when Chris is not able to articulate to me that he is in pain, his body language, his emotions show on his face. We can see when a child is in pain that they can't articulate, they may not have the right vocabulary. The same is true for somebody with dementia. We can see if they're in distress, if they're experiencing joy, but also experiencing pain. So that is down to the skill of whoever is supporting that person at the time, be it at home, in a hospital, in a care home.
Okay, thank you. Thank you for answering that. I have a question from Ziyue Wang for you, Romy. It's in regard to your presentation. You talked about needing to know more and not needing to know more. Could you a little bit expand on that? What makes the difference?
Yes, thank you for the question. So it was actually research done by others in people with late onset dementia, but it clearly showed that people with dementia and caregivers sort of oscillate between moments where they want a lot of information and other moments where they are actually trying to avoid getting more info on advanced care planning and on the condition of young onset dementia itself. So it might not always be a good idea to do ACP regardless of how patients and family caregivers are positioned in terms to wanting to know more. That's why we suggested this step-by-step information provision, really attuned to the individual position at that moment of patients and caregivers, to attune to their information needs at that current moment.
Okay, thank you for explaining, Romy. Then I have a question from Anne Chatters. Also, I think initially for you, Romy, how can the continuing need for review of ACP take place in the current medical social care landscape where appointments are limited with clinical staff?
Yes, that's a relevant question, of course. It is challenging to try to undertake ACP in every appointment. However, we focused our study on physicians clearly, but there is also room for other professional caregivers to engage in advanced care planning with patients. So this might already make sure that there is some type of delegation in advanced care planning. However, whether you consider it to be a one-time long conversation or whether you pick it up at several instances over the course of following up on a patient and a caregiver, I don't know if that will make the biggest difference time-wise.
Mm-hmm. Chris and Jayne, maybe you will want to reflect on it. What is your experience if people have the time, healthcare professionals have to make the time to discuss?
We take it as we Chris with Young Onset, we have a Young Onset nurse, and she comes out once a year to do a review of Chris. We've actually refused the review, you know, to do all the testing and the questions and the formal review, because we don't see the need. We know whether Chris is advanced or not. So we then have a generalized conversation with her, which when we did do the testing, we could still do anyway. But we discuss with her regularly, at least once a year, and keep her updated as to Chris's wishes.
And I think it's good, as Romy was saying, for people to someone professional to lead on the conversation sometimes, because you don't know what you don't know. You need people to lead on subjects and tell you sometimes what's available out there, what decisions and options you have got. So I think it's a good for someone professional to lead on these conversations sometimes.
And they can also bring topics up, as Chris said, that we don't know about, such as DNR. Well, what on earth's DNR? I know what do not resuscitate is, but sometimes you read the acronyms. I didn't know what ADRT was, but I looked it up. So this is something that professionals need to remember. Don't use medical speak, don't use professional speak, use ordinary language speak, plain language. Where you have an acronym, please qualify the acronym. And then, so if you say, have you done a DNR? A DNR is a do not resuscitate. This means, because we didn't know anything about dementia before we were thrown into Dementiaville. And then Chris didn't become a person with COPD. He didn't become a person with arthritis. He became a person with dementia, full stop. So that whole holistic view needs to be considered at all points, because it's not necessary that Chris is going to die of dementia, but he's definitely going to die with it. So these are the sorts of things that the professionals need to inform us about.
And remind us to do these reviews. You know?
Mm-hmm. Okay. And any comments from you, Ori or Romy? Please do if you have any. Yeah?
Well, now we are speaking more elaborately again about DNRs and so advanced directives and documents. Of course, this is all very important in dementia, but I do want to add that we shouldn't reduce advanced care planning to solely writing up documents. That's actually the point of the whole presentation. I think making it a process of communication where your physicians and your caregivers and your family know what your preferences are is actually the main goal.
Mm-hmm. Thank you, Romy, for your addition. I have two questions combined from the chat, and that's for you all, I think. What would be your advice about starting a conversation about advanced care planning? And is there any checklist or whatever from all the topics that should be included? Is there any guide available currently? So maybe how do you start a conversation about advanced care planning? What would be a good way to approach this? Who wants to comment?
To start?
Yeah.
I think actually if you use the broader question of what matters most to you, you will get a lot of information about what a person finds important currently and for the future in terms of care. But we also made a recommendation, for instance, for physicians to explicitly ask people about their worries or concerns. Doesn't even have to be about medical care, but also, for instance, financial worries about going to residential care, worries about how the diagnosis affects younger children and adolescents. All of these instances can actually be used to start a broader conversation by physicians. services for people with young onset dementia. So one of the main worries of these people was that they would be provided with sedentary services and would be surrounded with people who are much, much older than themselves. And that was actually one of the main concerns. And so that, for instance, also answers a question in the chat. I saw a difference between young and late onset dementia, if we found any. Those type of worries were very explicitly linked to younger age.
Yeah, well, there's young onset and then there's older onset. There's also early onset.
Mm-hmm. Yes.
But I have got older friends now.
Mm-hmm.
So I don't mind mixing with older people. I just think that any care environment should be stage appropriate, not age. It's not about age. You know, I've got friends in the 80s and 90s and we get along very well.
Mm-hmm.
But I don't buy it. But I think people do get mixed up a lot with these services. Services are for everyone, but they need to be more stage appropriate.
Some of the issues we found with young onset and with young onset diagnosis as opposed to over 65 diagnosis, and that age barrier is a different topic, is that we very fortunately we have a young onset CPN, community psychiatric nurse, who asked us, what do people with dementia want? What do they want to do? And we said, well, what do you want to do? You know, what do you do in your spare time? She said, well, I like to go for meals. She goes on holidays every second week of the year. But we said, you know what? So do we. We like to do that. So she set up a young onset group and we went along purely to support her, because who wants to sit with a bunch of people with dementia? You know, and when we got there, we found actually they were just like us. They were other couples in the same stages, the same difficulties, the same problems.
Yes, there were different ages.
There were different ages, but all below the age of, they're actually below the age of 60. But this is about 10 years ago. So as we've progressed through, Chris is still below 65, but a lot of our peers have progressed and moved on to late stages. And what happens is, as people become less able to manage the environment of a social grouping, they naturally no longer attend by virtue of not being able to cope with the noisy environment or the circumstance or whatever difficulties preclude them. So it's also, it's almost a natural stepping back for the people with whose dementia progresses. And that is difficult to see, but it naturally slows down this stage appropriateness. Chris doesn't want to sit looking at his future. He knows very well, we've been around a long time. We know very well what Chris may be looking at if he survives that long, but he doesn't want to sit there looking at what is likely to become. So it's a case of having those services and not age appropriate, but stage appropriate. And
I'm in my last year of young onset. I will be with the older people.
But even if he survives for 10 years, he'll still be classed as young onset. As I say, that's a different topic. Maybe Dementia UK could bring up sometime. But yeah.
I am one of those old people.
Okay, we have still the question pending about any questionnaires or checklists or toolbox to help along the conversation about ACP. Is there some sort of box available? Do you know, maybe Romy?
At this point, actually, in my opinion, there is no sufficient checklist, let's say, for conducting ACP, no, in terms of the topics. So, for instance, we elaborate in the article that advanced directives, een negatieve wilsverklaring in Dutch, but so it's a living will, can be useful, for instance, to see what elements you want to have discussed as a no harm principle. But I saw in the chat that someone commented. I'm reading the same thing.
Maybe there was a suggestion in the chat. I think I missed it, But if anyone wants to drop it in the chat, that would be great. Even in another language, it's good to know if there are any questionnaires available. So let us know. I want to thank you all for being with us here at the webinar. Thank you, Romy. Thank you, Chris, Jayne, and Ori. And I want to head back to Tessa to close up the webinar today.
Thank you so much, Christian, for hosting, and Romy, Chris, Jayne, and Ori. That was very thought-provoking. Anything that we do find that we feel would be useful, questionnaire, whatever, we'll put into the follow-up email along with the recording and presentation. I want to just say to you that the next webinar will be in May the 14th, and it'll be on living alone with young onset dementia. And we'll pop at least a save the date into the follow-up email, and additional information will come in the Young Dementia Network news, which will be next week. I'm glad that another dog has made an appearance. Looks really lovely and cuddly. We've got pets galore on the webinar, but they're not necessarily presenting. That's lovely. Thank you so much for everyone coming. Thank you to all attendees. And yeah, look out for our next one in May. Thank you. Thank you so much.
And thank you for inviting us.